Hello, everyone, and welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I'm a filmmaker and writer, among a few other things, but I've been working with CCF for over 10 years, about 11 going on 12 years now, creating all kinds of videos, a live video series like the one you'll watch today, Q&A sessions, patient-centric documentaries, treatment-based videos, conference videos, all types of videos that are all free and at your disposal, but all with the same mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That is what we are here to do today. Now, if you are new to this journey, if you are new to the show, first of all, I want to say welcome, and I want to encourage you to say hello in the comments. Tell us where you're joining us from across the world. You can see some people who are regulars are always doing that. Skip says it's a beautiful day in Atlanta, pretty beautiful day in North Carolina as well. But the value of the show you're going to watch today is really twofold as far as I see it. One, we're going to hopefully answer some of your questions and the information you're going to get from our guest presenter. And two, the community that we've cultivated here at the show. Now, the net community overall is very, very strong. We can't take credit for that, although we've been a big part of that. But this show, even the people that are here every week, are very supportive, and I encourage you to reach out to them, embrace them. They will embrace you back. Ask them questions. The shared stories and shared experiences from the community are just as valuable. And I've heard from several doctors, several experts on the show, that it's also valuable for them. So not just within each other, but that doctors are actually learning from you, sharing your stories and experiences too. That is vital. That is so important and such a great point. And when I heard that and heard it echoed by several, it was really meaningful to me, and so I want to reiterate that as well. So before we get started, we want to thank our sponsors, because without them we couldn't do the show. And we have this disclaimer from Ipsen Biopharmaceuticals that says the opinions expressed by the guest presenters today, as well as the questions asked by you all, the audience at home, haven't been created or suggested ahead of time by Luncheon with the Expert sponsors. And CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. So audience members should not rely solely on the opinions and information expressed by the guests, and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Okay. So that last line is really the takeaway. We're going to give you some good general advice, some good answers to your questions, hopefully, but we don't know your specific case. So take that advice back to your home team, which does know your specific case, and make the best plan and path forward for you. I hear stories of this all the time, of people learning from this show, taking it back to their home team and using that. And that's what we have the show for. So that makes us very happy here. We're also very happy to welcome back to the show a multi-time guest, third time, I think, possibly. And we might have done the first iteration of this show was a monthly topic-based live show. Dr. Robert Ramirez, a great friend of the foundation, a great friend of the show, and a friend of mine. Dr. Ramirez, welcome back to the show. Happy to have you.
Rain, good to see you again. I'm glad to be back.
Absolutely. Now, I keep up with you quite a bit, but for those who aren't familiar with you, and I know a lot are because we've been talking about this show for a couple of months now, tell us a little bit about the role that you fill in this net community that we've alluded to. Where do your expertise lie?
Thanks, Rain. I'm a thoracic and neuroendocrine oncologist. I've been dealing with patients with neuroendocrine tumors for quite some time. I'm at Vanderbilt in Nashville, and where I see everything related to neuroendocrine, and also for my thoracic piece, also non-small cell and small cell lung cancers.
Got it. So, folks, I know that we the past few weeks, and actually I would say past few months, we've been talking a lot about lung nets, having a lot of questions about lung nets. Sometimes the people that we have on the show, that's not their specialty. It's kind of a well, I'm not going to speak out of turn, but I know it's almost its own thing. Dr. Ramirez, correct me if I'm saying it the wrong way or not being clear about it, but it's kind of off to the side. And obviously there's a big overlap, but a lot of times people if they're working in the GI area of neuroendocrine tumors, that's a whole different section for them. So I know all of you have been having many questions. I actually shared one of our produced videos that we did a few years ago that featured Dr. Ramirez a few weeks ago because of that interest. So go ahead and start sending in your questions. I got a little bit more housekeeping to do, but go ahead and start sending them in. The best thing that you can do for me, one, if someone is not here yet, if you don't see them yet, if they haven't said hello, and you know that they should be based off of who we have today, based off of something they've been struggling with, tag them in the comments, share the video. Let's get as many people here as possible. You can always watch the replay, but the real value is this interactive session, being able to get a question across to Dr. Ramirez today. And two, if you see a question in the sidebar that you also have or you're interested in the answer to, you can like it, love it, any of the emotions right under the comment. It just says like or reply. You can like it, and what that does is effectively upvotes it. If I see 8 people have the same question as I'm scrolling through the questions, I'll make sure to get that one across. A couple other tips to help get your question answered, because we inevitably get so many that we can't get to them all, is ask them, try to be as general as you can. I know sometimes we try to add a lot of information that's specific to our case, but doesn't necessarily help. Sometimes it does. Sometimes we'll ask for clarification, but just try to ask in generic chunks so that we can help answer in a generic way, because unless Dr. Ramirez is your doctor, we don't know your specific case, and it's really hard to really diagnose something in this format, but it's very easy to help get you down the next step of the journey, and that's what we're trying to do today. One more little tip that I saw someone wrote in about that has been helpful, and I try to remember to let you all know this. There is a closed caption or a subtitle feature at the bottom right hand corner of your Facebook viewer that you're watching this video in. There's a few icons, and one of them says CC. And if you do that, it will auto generate the captions. It's not 100% accurate because it's AI, but it's pretty daggone accurate. And it's very helpful for one, if you're from another country, and it's hard for you to keep up with what's being said. We're talking fast sometimes. We're talking about high level issues, concepts, medications, syndromes, etc. Or you might just be at work and not using the audio, and it allows you to read as the video is going on and therefore still getting the content. So there's a little tip for you. In the meantime, go ahead and start sending in your questions. We're going to start taking them and try to get to as many as possible. Brian says, my wife's oncologist, great doctor, great man. Brian, I just have to agree, my friend. Hello from Western Australia. Vicky, welcome. Oh my gosh, Dr. Ramirez. Thank you for sponsoring this. Dr. Ramirez is the best. We need a registry for dip neck patients. That's interesting, Sandra. Any thoughts on that, Dr. Ramirez?
I fully agree.
Yeah, I've had a lot of questions about dip neck that I've seen. So questions already rolling in as I anticipated. So Dr. Ramirez, we're going to go ahead and start taking some of them. Jennifer says, how often do you see atypical lung nets coming back? Fully resected, no POS, lymph nodes, clear DOTA scan. If they do come back, usually what time frame would that be in?
So very, very good question. So we'll sort of back up a little bit and talk about
read my mind.
Lung nets and the differences between the two. So lung nets represent about 25% of all neuroendocrine tumors. Still very under-researched, and we're actually presenting some of our data at NANETS this year, where we actually looked at the amount of research that is presented at national and international scientific meetings. So as you may be aware, there's only one FDA indicated medication for lung nets. So most of the data that we have for anything that we do is initially presented at scientific meetings. So we looked at what was being presented at our NANETS meeting, which is our big neuroendocrine society, and then we also looked at what's being presented at the World Lung Cancer meeting, which is a IASLC, which is over the big lung cancer organization. And it turns out that less than 20% of all presentations had to do with lung nets. So again, a little bit of a difference there, but in the or disparity there, but in the lung cancer world, it was about 0.5% being presented. And I think at this last meeting, we didn't have any presentations related to lung nets. So again, lots more, and so when people talk about research and the need for it, I mean, well, there you have it. And that's probably why we only have one actual FDA indicated drug. Now that doesn't mean that we don't have a whole host of other options for treatment, but we just need more. We just need to invest more into dedicated research for the pulmonary neuroendocrine tumors. So that said, when we look at the neuroendocrine tumors, the lung, we break them into different categories: typical and atypical carcinoid tumors, and then the higher grade neuroendocrine tumors. They're the large cell neuroendocrine carcinomas and small cell lung cancer. Those are by far the most frequent that we see, and those are more smoking related illnesses. Now the pulmonary carcinoid tumors tend to be on the lower end of the spectrum, broken into typical and atypical, and we differentiate those by what they look like underneath the microscope. Typicals behave a little bit better than atypicals. So to answer the question, the majority of times neither one of these things come back after they're completely resected. The atypicals come back more often than the typicals. And so when you read the literature, the 5-year survivals of typicals are close to 100%. Now, when you look at 5-year survivals of atypicals, that number drops down, but it's still north of 50%, so around 60% or so. Now that doesn't mean that all of these things are going to come back. Some of it has to do with how big the tumor is. Was there lymph node metastases? Which stations or how much lymph node metastasis was there? And these are things that we will watch, and even in the node negative patients, we continue to follow patients for at least 10 years after the resection, because sometimes these things recur late. Most of the time they'll pop up within the first few years. And so I follow patients with CTs a little bit more frequently for the first couple of years. And then if all looks well and not really high risk features, well, then I will space things out to yearly.
Got it. Thank you. And I appreciate your question. Lots of them rolling in now, so let's keep moving forward. From Florian, our friend from Germany, how is a CT guided biopsy of the lung done?
So good question. The whole reason to do a biopsy is to get tissue to see what we're dealing with. There's different ways to get tissue, with a CT guided biopsy being a very common way to do this. So the tumors, again, depending on where they're seen, most of the time they're picked up off of a CT in the first place. So it is similar to your actual CT, where the radiologist is actually able to localize or visualize that tumor. And based off of what it looks like on the CT in real time, they can actually take a needle and place it directly into that tumor, and they can actually see where they're going on the screen. It's actually pretty cool. When we look at the films, we can actually see that needle going into the tumor, and so we know they were there, and then we can, obviously that will get sent off to pathology to tell us what it is.
Got it. Thanks, Florian. Appreciate your question. Let me know if you have any more. Next question from Niam. I hope I'm pronouncing that correctly. Let me know if not. Dip neck patient, 3 weeks post-COVID, really struggling with shortness of breath and fatigue. Oxygen levels are fine. Is this to be expected? So a couple of things going on here. Sorry to hear about the COVID as well. Also, Dr. Ramirez, let's take a little bit of time, since we do get a lot of questions often about dip neck, to kind of establish what that is for anyone else who might be interested or curious, and then we can take Niam's question.
Thanks for that. So DIPNEC is an acronym. So it stands for diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. So DIPNEC. So what hyperplasia means is abnormal growth of cells or enlargement of cells. And so what we think DIPNEC is, so these pulmonary neuroendocrine cells are kind of scattered throughout the lungs, and what we think DIPNEC is a growth of these to a point where they can actually cause findings on symptoms related to obstruction of airways, which can cause primarily cough and shortness of breath. Now, we don't know exactly what causes this. That's the I and DIPNEC, idiopathic. But this we're seeing more and more of this actually. There was actually just a paper put out this year where they actually looked at, this was with our colleagues in England, and they actually looked at over 300 pulmonary carcinoid tumor patients. And it turns out of all of those, about 20% of them actually had DIPNEC associated with their carcinoid tumor. So the majority of, so we tend to think that this is a pre-malignant condition. So DIPNEC can go into or turn into an actual pulmonary carcinoid tumor. Doesn't always happen. People can have DIPNEC without pulmonary carcinoid tumors. People can have pulmonary carcinoid tumors without DIPNEC. So, and then people can have both, as I just mentioned. So that's sort of what DIPNEC is in a nutshell. It can cause, we see it primarily in females, middle-aged, where they often get diagnosed with asthma or COPD and have been on a variety of different inhalers and cough medicines and all of these things until somebody finally suspects this. So that's DIPNEC. Now, obviously, I don't need to explain COVID. We've all experienced this in one way, shape, or form.
Sure.
So COVID on top of DIPNEC can be problematic. DIPNEC, obviously a respiratory disease when it's symptomatic. Now again, not everybody is symptomatic from DIPNEC, and not everybody has a respiratory symptom due to COVID either. But when they do, when they overlap, it can cause a lot of problems. Primarily, what I see when this happens is more so this lingering effect due to COVID rather than a worsening syndrome due to DIPNEC. So that said, sometimes patients will benefit from inhalers or steroids, whereas they don't really benefit that much with DIPNEC. So I always will refer patients to our pulmonary colleagues to see if they're able to help out.
Got it. Thank you. Hopefully that helps, Neom. Let me know if not, or if you have any other questions. Sorry you've been experiencing that. And hopefully you will be able to work through those lingering COVID effects. Next question from Skip. Not clear what my lung biopsy means. Low-grade nets nesting in the lymphatics of the lungs. Could you clarify that, please?
That's sort of a weird way to phrase a pathology report, and I'm not sure if this was a lymph node biopsy, which it could be. Again, when we talk about neuroendocrine tumors of the lung, we want a little bit more information than that. And we will frequently I'll get a report like that, and I'll pick up the phone and talk to our pathologist and say, we need something better than this. Our pathologist wouldn't give that report, but we'll get reports from outside, and then we let our pathologist see this. So we want things like the presence or absence of necrosis, and we want a mitotic index, and that those two things will define typical versus atypical carcinoid tumors. So low grade that's reassuring that okay, maybe we're dealing with typical rather than atypical. Ki-67 is sometimes included in this or is helpful in this as well. But yeah, I'd want more information from our pathologist.
Got it. Thank you for that, Skip. From Joy, are they going to start looking into oxygenation receptors to purge these dead cells?
I am not aware of. I'll have to defer to my my preclinical people to this. I'm not aware of that.
Okay. Next question from Kate. Can you take lanreotide, estradiol, and cortisone shots all at the same time?
I don't see any reason why you could not.
Okay. From Shane, what does vessel stasis mean on a post-embolization report?
Okay, so this is an interesting question. So this you've had some interventional radiologists on your show in the past, and so embolization is a certain type of technique that we'll use primarily for patients with liver tumors, where the tumors are supplied with oxygen via blood vessels, right? So if you cut off that oxygen supply and you cut off the blood supply to those tumors, they die off. There's different ways to do embolization. There's something called radioembolization, where we're injecting radiation actually into that area, into that tumor. There is something called chemoembolization, where we're injecting chemotherapy as well as particles to cut off that blood supply to that tumor, and that kills it off. And then there's something called bland embolization, which is similar to chemoembolization without the chemo. So you're just cutting off that blood supply. So when they say vessel stasis, that's exactly what it is. It's that they injected those particles, and so now you've got no blood flow to that area. So that's what vessel stasis is. So the embolizations we use all the time are, the big question that comes up is which one do you do? And it really depends on the situation. Presence or absence of somatostatin receptors. There's actually a clinical trial going on right now to kind of guide us to say which one is the right one to do, because realistically we don't know chemoembolization versus bland embolization. Are the outcomes similar, or is one superior to the other? So stay tuned.
Got it. Thanks, Shane. Appreciate your question. Next question from Linda, who is based in Canada. How would we go about getting a second opinion from Dr. Ramirez?
So I think second opinions are very valuable. We often will many times will agree with the original opinion, but sometimes we say, we've got something better, or we would do something a little bit different. So we'll work with your physicians at home to kind of, provide a roadmap for them. And so we don't necessarily need to see you back every month or every 2 months or whatnot. Sometimes it's once every 6 months or a year. But we can also stay in touch, once you're an established patient. So that said, to get an opinion from me, you can just send you can call Vanderbilt. You can send me an email. Rain, you can put up my email on the screen, and then what we'll do is we'll get you over our navigator. Our navigator gathers all of the relevant clinical history, clinical information, all the documents, and then we get you set up. We work as part of a team here. We have a fully functional multidisciplinary team. I go with 2 different tumor boards, thoracic tumor board and neuroendocrine tumor board, and a lot of my patients get presented in both.
I was going to ask that, yeah.
Different personnel. So it's fully we run, and we have all the tools necessary.
Yeah, and this goes for Linda and anybody watching. I mean, I have never had, a specialist, a doctor, an expert on the show that has not encouraged second or even, beyond opinions. And the collaborative effort that Dr. Ramirez just described at his institution is reflected across the community in general. I mean, especially I think because this is a unique disease, people need to do that. Did you want to say something to that, Dr. Ramirez?
Yeah, I mean, and not just in between, this specialty center and
right.
the community. I mean, there, if you're in a place where like you can't get to me because of insurance or logistics or whatever, sometimes we can say, oh, well, you're in Canada. All right. We know docs in Toronto, and, that we would refer to, that can give you another
absolutely
opinion, or if you're in another part of the world, the neuroendocrine community is actually a pretty small community. So we all tend to know each other and sort of know who does what. So yeah, I think at least reach out with that question as far as, if you can't get to here, maybe we've got someone else we can send you to.
Absolutely. And that's a great point. I mean, Linda, the community that we alluded to at the beginning of the show exists within the patient, caregiver, support group, leader community, as well as the doctors, specialists, experts, and all that as well. And there's a big overlap. So it's that community aspect, that collaborative nature, that support is just as reflected in the expert community as well. Thank you for your question. Let me know if you have any more. From Eileen, I had a biopsy on Long Island, said atypical lung nets, had the lower left lobe removed on September 13th, but Mount Sinai carcinoid specialist said that it was typical. And the question is that odd? Does that happen? Could it have been misinterpreted? Could it have changed? I don't know.
Yeah. So your initial biopsy is usually off of a needle. Okay. Now sometimes the needle biopsies don't tell us the whole story. So when patients come in, and a lot of times we'll get the disclaimer from the pathologist on our pathology reports that say this is a needle biopsy, and the differentiation between typical and atypical is best done off of a surgical specimen. So it sounds like this was excised, and now this is actually turns into something, no findings of an atypical tumor, but more so of typical. So we see it the other way around as well. So that is, again, I think if there's any doubt, you have a second opinion. We always have, whenever we have a patient come in, we always obtain their pathology, the actual slides, and have our pathologist look at these slides to give us an idea. Do they agree with this, or is this something different? And so, sometimes it is. I had a patient recently, actually, who came to me with an endobronchial obstruction, and they did a biopsy, and they called this an atypical carcinoid tumor at the outside institution. So he gets put with me, and I schedule him for a DOTA PET scan. And about a day before he's supposed to get his DOTA PET, pathologist calls, and they say, I don't think this is an atypical carcinoid tumor. I think this is small cell lung cancer. And that changed everything. And so now, and so we, it's important, again, not just second opinions on the oncology side, but second opinions on the pathology side and the surgery side, so on and so forth.
Got it. Thank you. Next question from Jennifer. Are there any other testing? Is there any other testing you like to use to follow lung nets in addition to imaging?
Good question. So imaging is sort of the staple of how I follow patients. The other big thing on how I follow patients is how they're feeling. So I can have someone with a metastatic carcinoid tumor that is completely asymptomatic and the scans are otherwise stable, or maybe things are growing a millimeter here and there and we may not need to change things. If the scans are stable or growing a bit and the patient is getting worse, well then maybe we need to do something a little different. Now, when it comes down to biomarkers for lung nets, sometimes I'll start out with some biomarkers depending on their symptoms. If the biomarkers are otherwise negative at the initial presentation, there's usually not a reason to follow them. Because it doesn't really change what I would do moving forward. So for instance, patient is asymptomatic, scans are stable, but I've got a biomarker that is increasing. I don't know exactly what that means or what to do with it. Does that mean that I've got a lab error? Does that mean that the disease is about to progress but hasn't? Is it enough for me to say I need to change my therapy? So, and a lot of times you go down this rabbit hole of oh, this is increasing, so we've got to give you chemotherapy now, or we've got to do something different. I would prefer to wait for any changes on scans or symptoms, because those may or may not happen. So there's no evidence to say that if you change your therapy based on whatever marker you're following, that is going to translate into better outcomes.
Got him. Thanks, Jennifer. From Gumro, after chemotherapy, there's thrombocytopenia. Please tell me what happened, or why this occurs and how we can manage it.
So thrombocytopenia is low platelets. So your platelets are the substances in your blood that allow you to form a blood clot. So for instance, when you cut yourself, the platelets go to the surface and plug the hole. Patients with thrombocytopenia can be at increased risk of bleeding or easy bruising, depending on how low it goes. So we see thrombocytopenia happen following many different types of chemotherapy and also PRRT, where we give the platelets start out normal, we give the treatment, they drop down, and by the time they come back to the next visit, hopefully the platelets are coming back up, or at least at a point where it's acceptable to give another round of treatment. Sometimes they're not back up and we have to hold the dose of things or change the dose. It is really uncommon for platelets to drop down really significantly, and what we do anyway, to a point where we're really worried about bleeding. And some of the other types of chemotherapy, platelets can really drop down. So that said, what can you do about it? Not much. You wait for things to come back up. If it's low enough, if you're symptomatic, we sometimes will do a platelet transfusion, but that's pretty uncommon in our world. And in other types of cancers, yeah, we certainly will see that a little more commonly.
Got it. Thank you. And thanks, Guma, for your question. And I think that's the first time I've seen your name on the show. So if this is your first time here, welcome. Appreciate you being here. Appreciate your question. From Tiffany, question: at the time of my mom's diagnosis, the doctor said it was not a hereditary type of cancer. Is that still correct? Do I have a high chance of getting it because she has it? And we don't have any context about where this originated, but this is a question we get a lot, so I want to try to at least address it in some form or fashion.
Sure. Yeah, and I get that question a lot too. What do I do? What do I tell the kids, and what do I?
Yeah.
They need to get tested, and usually this is not a hereditary disease. Every now and again, it can be. And the people I suspect that in are people who have, one, there's no real risk factors for this, right? We don't know what causes neuroendocrine tumors most of the time. Again, every now and again, we get this hereditary part of it. But the people who I suspect that in are those who have multiple primary tumors. So for instance, a primary tumor of the lung that gets taken out, and then a few years later, they pop up with a primary tumor in the pancreas, or if these are the patients that, the red flags go up and say, all right, well, maybe we're dealing with something with this. And these are the ones I'm sending to our geneticist and saying, all right, well, what do we have going on here? Or if those patients who say, yeah, my mother had a lung tumor removed and a pancreas tumor removed. Oh, and now I have a confirmed cancer of the lung. Again, it's one thing to have suspicion, but it's another, all of that suspicion needs to be, confirmed before we even go down that road of this being a genetic syndrome.
Got it. Thank you. Appreciate your question. Next question from Eileen. I had the left lower lobe removed 3 weeks ago. Had to have drainage of fluid, 1,500 cc's from the lung space 2 days ago. Is there anything that I should be doing to ward off the return of fluid other than just monitoring by X-ray?
Yeah, there's probably not much you're going to be able to do, but stay on top of your symptoms. I mean, that's sort of the big thing. So, the fluid causes, you probably know, causes shortness of breath, sometimes some cough. And if you notice these things coming back, we take that, that's going to require another drainage.
Thanks, Eileen. Hopefully that helps. From Patty, how often should a chest CT be repeated when there are multiple lung nodules?
So it depends on the situation. So if you're on treatment, if you're not on treatment, how long the stability of the nodules are. If I've got patients with multiple lung nodules that I have on chemo, many times I'm repeating it every 3 months. If they're lung nodules that have been stable for a decade, well then maybe I can space this out to yearly. If they're on another, sometimes it's 6 months. So it really depends on the situation. Are these things growing, or just what's going on? So it varies.
From Jennifer, do you like to do full body scans in addition to the chest CT for lung primary for follow-up?
So usually, so that's a good question. So usually what happens when a patient comes in with a lung primary, so we'll do a couple scans. So one, we'll do a CT scan of the chest if we think there's liver involvement or adrenal involvement. We'll add an MRI or a CT of the abdomen. Most of the time, the CTs of the chest actually pick up the upper portion of the abdomen, so we can pick up the liver and the adrenals. But we also at least initially, we'll start out with a DOTA scan as well. So that'll give us a little bit better idea is, one, do the tumors have somatostatin receptors? And then two, is there other evidence of distant disease? So similar to my non-small cell patients, I'll do a CT and then also an FDG PET, so different types of PETs. So after surgery, usually just followed with CT alone. When I flip to getting a PET on somebody is more when something new develops. So a new nodule or enlargement of lymph nodes or something pops up in a liver or bone, then we start over again and get that PET again. So usually it's followed just with CT. If there's something new, then I get a PET.
All right, thank you. Appreciate your question. This is a question from Ruslan for their father-in-law. My father-in-law has recently been diagnosed with neuroendocrine tumor favoring carcinoid tumor through core biopsy of the mediastinal mass. We are looking for options for treatment. Do you think this tumor is operable or curable? How can we contact for video consultation? He's currently living in Bangladesh. So this is a big, broad question, but Ruslan needs some help. I want to try to give it to them.
Yeah. So a few things in that story. So the patient had a needle biopsy of a mediastinal mass, so right in the middle of the chest. So this kind of goes along either with a thymic neuroendocrine tumor or sometimes a pulmonary carcinoid tumor. Again, it's hard to tell without actually seeing pictures and knowing more of the story. Most of the time, if we can take it out, we take it out. But sometimes especially the thymic neuroendocrine tumors, by the time they're discovered, they're pretty big and sometimes wrapped around vessels and airways. I think it's up to the surgeon to say whether or not this is operable or not. If we can take it out, we take it out. Sometimes there's a role for chemotherapy to try to shrink the tumor to make it a borderline operable candidate, clearly operable. If we see initially that there's no way we're going to be able to operate on this, well then it would be really unusual to go from a clearly non-operable to operable even with treatment. So yeah, I encourage encourage you to be seen at a high volume center with experienced thoracic surgeons who are going to be able to say what we're able to do. But similarly, it needs that workup. Is this really a carcinoid tumor? Is there access to a DOTA scan, so on and so forth?
And Ruslan, a couple of comments above yours. We put Dr. Ramirez's information in there as he allowed us to do, and I want to reiterate his point that he made about seeking a second opinion. Because Ruslan was asking about video consultation with someone else. So hopefully there's someone else that you can reach to try to understand. I know Effie says, I consulted with Dr. Ramirez for a second opinion and it was well worth it. Everyone was so supportive and easy to work with. So we want to try to help. Reach out to us if you have any other questions, and all our best to your father-in-law. Folks, we got about 15 minutes left, so we are moving right along today. Keep sending those questions in. From Connie, when does surgery become an indication with low-grade lung NANETS?
So the short answer is it's always a consideration. So low grade, if someone comes in with an isolated tumor, do a biopsy and it says low grade, the treatment of choice is surgery. So that's the bottom line. We take it out. Now, if we're in a situation where the patient we're not able to take it out for whatever reason, they're not a candidate for an operation for whatever reason, they don't want an operation. Sometimes there's a role for something called stereotactic body radiotherapy, which is or SBRT, which is a high dose of radiation directed right at that tumor. That we use this all the time in patients with non-small cell lung cancer. Now, you can imagine in non-small cell, this is usually a smoker's illness. So those folks, sometimes they don't have good lung function and you go and do an operation on them and you make them worse from a respiratory standpoint. So we always check breathing tests and beforehand to kind of see how our patient's going to do with their surgery. Now that said, so we've got, in those patients who are not candidates, SBRT has a clear role and very good outcomes. Now we're getting more and more information about SBRT with carcinoids, and indeed this is beneficial. So I think that could certainly be a consideration. Sometimes if it's an endobronchial lesion, sometimes we'll do endobronchial therapy. We've got a paper coming out here, hopefully in the coming months that discusses this whole workup and management of the pulmonary carcinoid tumors, including PRRT and SBRT and endobronchial therapy. So stay tuned for that.
Got it. Thank you. So Melinda says, Dr. Ramirez, can you recommend any breathing exercises for dip neck / lung nets?
So I think so. Yeah, very good question. I think one, you got to sort of assess, where what's your baseline level? Do we have recent PFTs and that, or pulmonary function testing? And that will give us sort of this objective view of what's going on. Those are things that will follow over time as well. So we'll do PFTs at some time point over the course of a year or 6 months. We'll repeat PFTs and see how things are going. I think that the biggest thing is to get out and try to exercise, try to do, sometimes we send people to pulmonary rehab where they can actually formally, do these breathing exercises. And I don't know if that's necessary for everybody, but I think the more active you are, the more you're able to move that air in and out. I think the better off you are.
Got it. Thank you. Hopefully that helps, Melinda. Appreciate your question. Next question from Karen. I have confirmed dip neck after a typical carcinoid lower left lobe removed. Can fluid in the lung cause AFib?
It's a good question. So usually, I don't usually see a pleural effusion causing AFib. Certainly people can get AFib after surgery. AFib's pretty common, regardless. So I think we treat it the same, and with our cardiology colleagues, and there's medicine. Sometimes we do some electrical therapy to the heart to shock it back into a rhythm. So there's different ways to do it. So I would just consult with the cardiologist.
Got it. Thank you. All right, folks, moving along. This is a more generic question, but Jennifer says, how do you determine where the primary site is? And if the primary is unknown, how may that change monitoring?
So good question. Most of the time we're able to find the primary. So someone comes in with a bowel obstruction, with symptoms of abdominal pain, nausea, and vomiting, and we look at the scans and we say, oh, you've got a big mass in your small intestine. There's your primary. But sometimes people come in with disease within their liver, and we biopsy it and we say, oh, this is a neuroendocrine tumor. And then we do the scans and we say, wait, you don't have anything in your lungs or belly that we can see, you just have disease in your liver. So it's somewhat, it sometimes we see that. It's not all the time, but we see that. Sometimes that is where, so the PET can sometimes tell us, if you've got one small thing that lit up in your small intestine, and now you've got a liver full of disease, that can certainly happen. So that can give us some clues. Sometimes this is where there's certain types of molecular analysis that can guide us as to a primary location as well. There's a few different companies that do this, so we'll sometimes do that. And why it matters is, one, treatments can vary because of this. Sometimes there may be a role for surgical resection of, so really, we try to determine the primary. Most of the time we can, sometimes we can't, and even, I've had patients who've had tumors that were taken out, gosh, years before, like decades before, and then they come back with liver disease, and we say, all right, well, where's your primary? We don't know. And they say, oh, wait a minute, 20 years ago I had this tumor taken out. They told me this was a benign thing, and of course there's no records available or anything. So most of the time we can find it. I think it does make a difference in many cases, but there's a lot of overlap as well.
Got it. Thanks for your question, Jennifer. From Claire, how often do you repeat dotatate PET scan following an atypical NET?
So again, so usually, if it's something that I can see on a CT, and I've got a PET that correlates with that CT, usually I can follow people with CTs. Sometimes, though, I'll have patients with pretty widespread disease that is a lot of times uptake in bone in the skull or in the long bones of the leg, and those are the patients that I'm primarily following with PET. So again, it really varies. Most of the time CT, sometimes with PET.
Got it. We've got time for a few more. Next one comes from Jackie. Do you have any suggestions on how a patient could receive a dotatate scan, for example, if family doctor is uninterested in sending me for any tests because my CBC was fine? So they say I don't need other workup. However, I have had a malignant carcinoid tumor, small, removed from the appendix years ago, but going through extreme flushing and many other carcinoid symptoms for the last 2 years, and it's getting worse. So Jackie wants a dotatate scan, and the doctor doesn't necessarily agree.
Yeah, well, that sounds like this is that perfect case for a second opinion, and I think all of us will see patients with these diagnoses, and part of the guidelines is, well, if you haven't had a dotatate scan, that's indicated. That's part of the workup here. Mm-hmm. So yeah, I think second opinions, again, even if you came and saw us, we would put in or schedule an appointment with us. We would get a dotatate scan on you as part of our intake procedure. Even before you had seen us. So I think that's one option. I think education. We see this all the time where we make recommendations, and the docs, it's a rare disease, and most of the time the docs who are not familiar, with this, and they're seeing, you mentioned if this was a family physician, so they're not seeing this, probably don't know all the nuances of this. So we are always happy to discuss with your docs as well. So if they, if you say, look, if they want to send me an email or a phone call. I just spoke with a doc this morning about a patient who I've never met this doc, and they just had questions about what to do moving forward. So it's a pretty this part of what we do, what we all do.
Yeah, Jackie, I would definitely take them up on that for sure. But thanks for your question. From Jennifer, does the PFT normal range change after a lung surgery?
So not necessarily. I mean, we calculate percentages of this. So we will be able to, tell you, based on what procedure you had done, what your expected is, and then calculate a percentage. So, where we see things change is, as lung disease worsens. And I see this in my patients who smoke is we'll get PFTs at one time point, and then they continue to smoke or have different insults to their lung, the PFT range will go down.
Got it. From Sandra, is there a specific reason between recommended Octreotide or Lanreotide? A question often asked.
Yeah. So we tend to, there's different indications for both of them. Octreotide, the FDA approvals are for treatment of patients with carcinoid syndrome. Lanreotide is the FDA indications are for carcinoid syndrome and tumor control. Now in reality, the Octreotide works for tumor control as well. But there's different delivery systems. There's some people who tolerate one better than the other. When patients come in to see me, usually if they have not been started on anything, and I think a somatostatin analog is indicated, I'll start them on Lanreotide simply because of the data behind it. If they come in and they're on Octreotide and they're doing well, I don't see a reason to switch if they're doing well. If they're having problems with it, or if I think it's not being administered correctly, then sometimes we talk about switching. I think the studies with the Lanreotide were a little bit more robust. Lanreotide has data in lung as well, so that's another reason I use this. So are they the same? They haven't been compared head to head, and they never will be. So,
got it. Thank you. From Lisa, or can NETs metastasize to the eye from a lung primary? Recent eye doctor appointment identified a raised spot on the retina, and she's waiting to see a specialist.
I guess it's theoretically possible. It would be extremely uncommon. I've never seen it.
Okay, Lisa, please, stay in touch. Let us know once you do see the specialist. And last question, probably, Joanne says, any input on Lutathera? Does it work?
So Lutathera works. So this is one of the big things that we've been doing it for years now. And so we and even before the FDA approval, we would send people out to have this done
for sure.
To different countries. So Lutathera works. Is it FDA indicated in lung? No, it's not. But it doesn't mean that we can't use it in lung. It's guideline indicated. So all of our guidelines tell us, oh yes, consider Lutathera in this patient population. So there's a trial ongoing now. We're opening this up shortly that is actually looking at patients with lung nets who have disease that has progressed and randomizing them to actually either Lutathera or the FDA indicated everolimus. So at the end of the day, we're going to say, all right, which one, in lung nets, which one is actually the best one to go with initially. So I think that trial is years away from results. Just started. So maybe that'll help answer some questions.
Hopefully. Well, I appreciate your question, Joanne. And folks, that is our hour today with Dr. Ramirez. Jackie says, your words are a godsend. Thank you so very, very much. And I agree, Dr. Ramirez. I thank you for being here and spending some time with us, sharing your experience and knowledge again with the CCF community. Thank you.
Happy to help.
Absolutely. And thanks to you folks at home. As always, we hope this program helped answer some of your questions. I'll reiterate, the video will be able to be replayed as soon as this is done. It'll post itself onto Facebook, and starting next week, we'll repost it to YouTube for anyone who doesn't have Facebook if they want to be able to watch it. And if you have any other questions, please reach out to Carcinoid Cancer Foundation, either here at the Facebook page or at carcinoid.org. Thanks again to our presenting sponsor, Ipsen Biopharmaceuticals. Without their support, we couldn't do the show. And finally, my name is Rain Bennett. Thank you for watching. Please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everyone.